All right, you guys, this module here is going to cover fluids, electrolytes, some TPN basics, and also I'll cover some vitamins. But for the most part, it's going to cover fluid and electrolyte management because that's one of the basic cornerstones of nursing care or patient care. Most disease processes, tissues, injuries, surgical procedures, greatly influence the physiological status of fluids and electrolytes in the body. And it's important to know that these body fluids provide transportation of nutrients to the cells and carry waste away from the cells. And so having a really good solid foundation of fluid and electrolyte management will help you a lot in your nursing practice in general. So water makes up approximately 60% of an adult's body weight. That's referred to as TBW, or total body water. It is important to know that older adults might be 45 to 50% of that, and an infant could be as much as 70 to 80% total body water. So this places them at a higher risk for fluid imbalances. Just tuck that away in your mind somewhere. Of that total body water, 2/3 of that is intracellular. That means it's inside the cell, right? Which leaves the other 1/3 of that water is extracellular, and that is actually split up into two more parts, with about 1/3 of that extracellular inside the plasma. So about 1/3 of the third, if that makes sense, is in the vascular system. And the other 2/3 of that third is in between the cells, which is what interstitial means, right? So that would be your buffer, your padding in between all the cells. And then there is some trace amounts of fluid that we find in aqueous humor, which would be like your tears, in the intestinal tract, in the pleural space, saliva, things like that. Just trace amounts there. So any shift in any of those places of that 60% could have a dramatic effect on the fluid electrolyte balance. And some other terms that I want you to be familiar with, if you go back to anatomy and physiology, would be osmosis. Osmosis is, remember, that's where diffusion, where water moves from a lower solute concentration to a higher solute concentration, which is what happens from the vascular space. And we'll talk about that more when we start talking about the specific types of fluids. When we're talking about active transport, this is the sodium-potassium pump. Remember the ATP pump that needs energy to move that through, and we'll talk about that a little bit when we talk about electrolytes. And then osmolality, that is the number of solutes that are dissolved in 1 liter of fluid. It really is a measurement. So when we talk about osmosis, we're talking about movement, and when we talk about osmolality, we're talking about measuring something. Usually when we do that, we're measuring sodium, glucose, urea. Those are the top 3 solutes that usually are used to determine a fluid's osmolality. But another thing that we might look at is, if we're looking at the blood, we might use a hematocrit to do that. If we're looking at an HGB, where would I see those numbers fluctuate? If determined by the amount of plasma that's in the blood. And we could talk about that as well. So what would a hematocrit look like in a dehydrated patient? Would I see lots of red blood cells, or would I see not very many blood cells? Think about that for a minute. If I take some of that plasma away, I'm going to see a higher number of red blood cells, right? Anyway, that's what osmolality is. So the goal of fluid and electrolyte balance in our body is to maintain what we call homeostasis, which we're trying to keep an equal balance between what comes in and what goes out. And there's lots of different mechanisms in the body that will help us achieve that. If you're a little low on your fluids, the first thing that's going to happen is your body's going to trigger a thirst response. You're going to think, oh my gosh, I'm thirsty. I need to take a little bit in. Your brain's telling you to do that without you even know what's happening. We've got other things that are happening like the body producing anti-diuretic hormone. That's it triggering for your body, for your kidneys not to release so much fluid. It needs to hold on to a little bit, or aldosterone. Um, and it's really important that we keep that homeostasis because all that water in our body is used to dissolve solutes. It's a solvent that dissolves solutes, and it also acts as a medium for metabolic reactions. So it moves pretty freely between all these places, these compartments we talked about, from the intracellular to the extracellular spaces, the interstitial, and it does that through the active transport and through osmosis, but also through diffusion, which, if you remember right, diffusion is just kind of like gravity. It just kind of falls on through, and also through filtration systems. Fluid intake primarily comes from fluids, but we can also get water through solid foods, through IV fluids that are given, or through parenteral fluids, which would be like TPN. And we primarily lose it through the kidneys, through urine excretion. But we can also use it, we can lose it in the form of emesis or feces, as well as some sweat and breathing. The respiratory system, when you breathe in and out, gets a little bit of fluid, goes with that. And also through the GI tract. And then extra things would be like if your patient has any drains, fistulas, if you're actively suctioning, that's going to remove some fluid. And we do measure that because it can make a difference in a critical patient's fluid balance. So anytime we see a sudden change in weight, whether it's plus or minus, that most likely is going to lead or is caused by a fluid imbalance. And it's important that we understand why. So there's some things that you should be aware of as you're doing nursing assessments where you're looking for fluid imbalance. So here's just a really quick overview on what you might be looking for in a fluid balance assessment. So what if you had a patient that had fluid overload? What would you be seeing there? When I think of fluid overload, I immediately think of a patient that has like heart failure. What's going to happen if the heart's not contracting enough and fluid is building up? What am I going to see there? It depends on if it's right-sided or left-sided, but I'm going to see things like edema, especially down in the feet. And if it's going up higher and into the hands, then I know it's more pronounced, right? That's a lot of fluid backup by the time it reaches the hands, or especially up in the jugular, in the neck. If you see jugular distension there, then it's pretty pronounced. I might hear it in their lungs when I'm assessing the crackles in the lungs from the fluid overload in there. What would you feel if you're assessing their pulses? I mean, it's going to be really strong and bounding, right? Blood pressure is probably going to be high. You're going to see some hypertension. Your patient might be coughing. They might have a hard time breathing. Stuff like that. What would you see if you were looking at their labs? Especially if I'm looking at like their BUN or their hemoglobin and hematocrit. That's that, oh, my mind just went blank. That's the osmolality where we're looking for a fluid imbalance there. A lactate also could point towards dehydration. So if I were assessing a patient that had dehydration or a fluid deficit, what would I see? Dry mucous membranes, they might be complaining that they're super thirsty. Really poor skin turgor, you know, where you tent up the skin, and if it doesn't go snap right back, if it stays in that tent, then you know they've got some dehydration there. Really be watching their urine output. You need to be reporting a patient that's not, their output isn't at least 30 mils an hour. That doesn't mean you want them up every single hour doing 30 mils, though that could happen. But, you know, you do the math throughout your shift. If you've got a relatively healthy patient on a med-surg floor, you'll probably calculate that through the shift. But if you're in an ICU, we're usually doing that every hour. Occasionally you'll have a doctor that will order strict I's and O's, where that has to be what's going in and what's going out is recorded hourly. And if they don't get up to use the bathroom that hour, then they don't get up to use the bathroom. It might be 3 hours before they use the bathroom, but if it's been 3 hours, then they better give me a minimum of 90, right? Sometimes you got to do the math there. Somebody else that's volume deficit might be tachycardic. And why? Why would that be happening? It depends on where the deficit is. If it's in the vascular system, the heart's trying to pump faster to get more coming through because that blood is carrying oxygen, right? And oxygen is life. So hypotension would be another thing where you see the blood pressure be lower. Let's see, we talked about you should be taking vital signs, you should be watching their blood pressure, you should be watching their heart rate, but also their oxygen saturation could point you to be looking at some dehydration if the oxygen is dropping. I talked about the fluid intake and output. Daily weights, that's pretty standard in a hospital setting, at least once a shift. But if you've got a patient that, like I said, is heart failure or something, then it probably will be, or not once a day. Usually they're once a day, but if it's somebody that needs it more often, it's probably once a shift. Cerebral edema. What would you be looking for there? That's not something that usually you can visually see, but it's something that you can subjectively have reported. The patient is probably going to complain of a headache. They might be acting kind of confused. If you see that they're getting disoriented and they weren't previously, or especially if they've got a loss of consciousness, they might be getting really irritable with you. They might be experiencing nausea. They might be vomiting, especially if they're projectile vomiting. Difficulty speaking. They're complaining of neck pain. Pinpoint pupils. Pinpoint pupils is a pretty later sign, a more ominous sign that you don't want to see there. Anyway, be doing those neuro checks. If your patient is starting to act a little funky, get them in for a CT scan, an MRI, something. And we'll talk about what might cause that cerebral edema when we talk about your fluids. And then your third spacing. Have any of you ever got to do some abdominal percussion? I think most of the time when I assess and see third spacing, it's in the liver area with like, oh, my mind just went blank. Sorry. Like cirrhosis of the liver. You could see some fluid there, and it's kind of fun. I encourage you when you're doing your assessments to practice that percussion when you're assessing the stomach. Do it last because you don't want it to be stimulating bowel sounds that wouldn't normally be there. But learn what it sounds like when it's got an organ behind it, or when there's fluid behind it, or when it's air trap behind it, when it's soft, when it's firm. Get really familiar with what those normals are, so that you can clue in when something isn't normal. Okay, so when we talk about intravenous fluids, we're talking about these three different categories. We've got isotonic, hypotonic, and hypertonic. So isotonic is, it's the one that most closely mimics the fluids that are found naturally in the body. And the most common one is just NS, normal saline, which is 0.9% sodium chloride added to water. That's all that's in NS. Hypotonic would have less solutes to it. So like say, for example, half NS. And hypertonic would have extra solutes, which an example would be like 3% sodium chloride. And we'll talk about those on the next slides. So like I said, isotonic solutions most closely mimic the fluid that's already in the body. It's primarily the biggest electrolyte added to an isotonic solution would be sodium chloride, because that's present throughout the body's water already, and there aren't any hypersensitivity reactions to it. It's safe to administer during any stage of pregnancy. It really is only contraindicated if a patient has hypernatremia, and we don't want to be adding more to that. But it's the perfect solution to be using for somebody that we're just maintaining balance. We aren't trying to put fluid into certain places or draw it away from certain places. We just want to keep that homeostasis balanced. Maybe they've got a little low blood pressure, and we're trying to just beef up the amount in the vascular space a little bit. That's pretty common when we give a bolus to help bump that up a little bit, because it primarily stays there because it doesn't have that osmotic pressure to push it somewhere else. The osmosis is not working to pull solutes somewhere else. It kind of stays where you put it. And like I said, normal saline is the most common kind, but the other kinds of isotonic solutions that you'll come across would be lactated ringers or 5% dextrose in water. That's in free water. It's really important for you to know that if we're adding dextrose to any other solution that has other solutes in it, it's not going to be an isotonic solution anymore. So only 5% dextrose in free water is isotonic. Lactated ringers is a solution that has mostly sodium added to the bag, but there's also some potassium there, some chloride, calcium, and lactate. And it's a favorite for surgeons to use pre-surgery, and maybe finish out the bag once they're back on the floor, and then most surgeons will have you switch back to normal saline, because some of those electrolytes are lost during surgery, but they don't need to be consistently being replaced over long periods of time. Okay, so isotonic is used when it's desirable to expand the extracellular fluid or just maintain homeostasis. Okay, so when I talk about hypotonic or hypertonic, I think the easiest way for me to explain it is that the solution, the liquid that you're putting in through the IV wants to go where the party is. Okay, the fluid wants to follow the party. And when I say the party, I mean the solute. So if I were to put a hypotonic solution through an IV, it most likely is going to not stay in the vascular cell, or into the vascular space. It's most likely going to go into the cells, because that's where the party is. And this is the perfect solution to use for somebody that's dehydrated. If they've got intracellular dehydration, we would typically give a hypotonic solution to help get that fluid into those cells where it needs to be. The most common one that you would see here would be, we call it half NS because it's 0.45, and normal saline is 0.9. So half of 0.9 is 0.45, right? So half NS. You might encounter a quarter NS. It's pretty rare that you would. That's almost free water, and we don't administer, just file away somewhere that we don't administer free water anywhere, because that could lead to, very quickly could lead to cerebral edema. So just be thinking, you might give it to a patient who's hypernatremic or hyperglycemic because the intravascular space already has too much stuff. And we're trying to dilute that there. We're not trying to really get a fluid they're not really dehydrated, and they need some fluids, but we're trying to get some homeostasis within the vascular space, and so we'll add a fluid that's going to put more fluid volume there with not so much sodium going in, or trying to balance out the excess because glucose is a solute that's measured as well. So just remember, hypotonic will plump up the cells. It seems opposite, but think of a hippo. Think of the cell as a big fat hippo, because it's going to go into the cells. And the opposite would be the effect of hypertonic solutions, because when I'm administering like 3% sodium chloride or 5% dextrose in normal saline or 5% dextrose in LR, I am administering a fluid volume that has more of the party. I'm putting more of the party into the vascular space. And so if I've got more party into the vascular space, where is fluid from the cells going to go? Is it going to want to stay where it is, or is it going to leave the cell and go into the bloodstream? That's exactly what we want to happen when we're giving a hypertonic solution. It expands the plasma volume by drawing water away from the cells and the tissues. So we would use this to relieve cellular edema, especially cerebral edema. Like I said, we don't give free water because we don't want it to cross that into the brain and give that pressure there where it doesn't. You know, when we have excess water in other places in the body, the edema, the skin stretches, it can weep out, we can see the third spacing. But in the brain, there isn't anywhere for it to go, and it's pushing on the brain stem, and it leads to, well, death. It'll lead to, if it herniates the brain stem, then it's going to be death. And so there just isn't really enough places for swelling to be in the brain. So this is a fluid that we would administer slowly, because we don't want to bring fluid out of the brain tissues too quickly or too much of it. We don't want to have dehydration in the brain cells either. But this is something that we would monitor closely to do that. It also could be a solution that's chosen for somebody who is, I would say, severely hyponatremic. For somebody that just is like 132 or even maybe like 128, and we want to, you know, balance out the electrolytes, usually we would just give NS and just watch that lab, because we don't want sodium to come up too fast ever. But if they are severely hyponatremic, then expect to see 3% used very cautiously. Probably in an ICU setting only, on cardiac monitoring with hourly neuro checks, things like that. So remember that electrolytes are salts that have either a positive or a negative charge that generates electrical impulses, and those impulses are used to contract muscles in the body, right? They're found either intra or extracellularly. The primary intracellular electrolytes include potassium, magnesium, and calcium, and the primary extracellular electrolytes are mainly sodium and calcium. But bear in mind that there is some sodium on the inside as well, and there is some potassium on the outside. In fact, you know, we measure potassium. We measure all of these electrolytes in the extracellular space, because we can't get that tiny little needle into that little cell to pull the fluid out to measure inside the cell. So just keep that in mind. The four that we'll talk about here is sodium, potassium, magnesium, and calcium. I do have listed the normal values for you here. I really encourage you to take the time to memorize those, especially sodium and potassium, because you're going to have so many questions pop up on your HESI and on your NCLEX that will give you lab values. And if you don't know what normal is, how can you know what abnormal is? And you're going to have to know based on whatever the question is, whether that's normal or abnormal, because that's going to drive your next step, right? So just take the time to memorize those now. You might, as you get out working in real hospitals, see that some of these values do vary slightly, and I don't want you to get hung up on that. It's just normals in a hospital are based on their specific calibration um, tools that they use, and so it could vary slightly, but these are the NCLEX values here, so take the time to memorize those. So we'll talk about sodium first. Remember that we find sodium primarily on the outside of the cell. Sodium does affect water distribution more than any other electrolyte. Where sodium goes, water wants to follow, or vice versa. Where water goes, sodium likes to follow. That's not always the case, but more often than not it is the general rule. It also likes to hang out with chloride and bicarbon in that relationship. It helps promote acid-base balance. So primarily we obtain our sodium through our dietary intake. And here in the United States, it is not difficult to maintain an adequate sodium amount. If anything, we're probably eating way too much of it. And it's important for you to realize where that sodium hides, because in your career, you're going to do, most likely you're going to provide a lot of patient education related to like cardiac diets, low sodium diets, and it's important that you can help your people that you're teaching identify where that sodium is when it's hiding. It's primarily in, like, used as a preservative or in soda. If people are fixing their own home cooked meals and just using, you know, a little salt shaker here and there, you'll be well within the normal dietary guidelines. It's when we start using everything that's prepackaged that we run into a lot of trouble. Anyway, it's found in salt, meat, fish, other foods that are flavored, seasoned, preserved. The body tries to keeps a very tight control on sodium through different mechanisms, primarily by thirst. If you're thirsty, then you probably need to take in more fluid to help that balance. And also by the secretion of antidiuretic hormone and through renal mechanisms. When we're talking about hyponatremia, that's where we're seeing a sodium level less than 135. And some of the symptoms that you might see in a patient that's hyponatremic, especially if it's really a low level, would be lethargy, hypotension, stomach cramps, vomiting, diarrhea, and even seizures. So when we see hypotension, remember that if their sodium's low, probably the fluid in the vascular system is going to be low too, which is going to lower that. And in that same vein, if they've got hypotension, you're probably going to see some tachycardia associated with that, and be paying attention to their oxygen saturation, because if they don't have the blood volume in the veins, they aren't probably providing enough oxygen to their cells, which could contribute to that lethargy. And often we'll see confusion where they're just not getting enough oxygenation to the brain. So be very mindful of that. SIADH, if you remember, that's the syndrome of inappropriate antidiuretic hormone. That can actually cause a state of hyponatremia, and it's not that the body doesn't have enough sodium, it's that it's retaining way too much water, which is just really a dilutional problem more than anything, but the patient could exhibit the same symptoms of hyponatremia just as much as if they were dehydrated. So hypernatremia is where the sodium content is above 145. And some signs and symptoms of that could be muscle cramping, headache, lethargy again, seizures, coma, and even possible intracranial hemorrhage. That's very important that you understand the possible intracranial hemorrhage component of that as the fluid is shifting into the brain cells inappropriately. Let's go back up and talk about hyponatremia again just for a second, because I want to point out whenever whenever we are doing sodium replacement, we do it very, very slowly. So if you've got a patient that's under 135, if they're just a little under 135, we'll probably just try to replace it with a change in diet, or maybe just, you know, some regular fluid maintenance like NS would be very appropriate there, as long as they can tolerate that fluid, that they don't have heart failure or other symptoms of fluid overload. But if they're really low, that doctor might prescribe for you to run a bag or two of like 3% NS, which is a very hypertonic solution that we already talked about. And it's important for you to know that if we bring sodium up too quickly, there's a really high risk of the patient developing what is called osmotic demyelination syndrome. And that's where the myelin sheath that covers the nerve cells is destroyed. It's very similar if you think of, if you've studied multiple sclerosis yet, you know, that myelin sheath is very important in the transmission of the neuron as it goes along the neural pathway, because it jumps from point to point to point and makes it very fast. And if that myelin sheath is destroyed, then it very, very much slows down that process, right? The problem with this osmotic demyelination syndrome is that it's happening in the middle of the brainstem specifically. It's not like MS where it's body system wide. It is very concentrated there in the brainstem and a few other parts of the brain as well. But the results of that brain cell dysfunction the effects can be devastating and permanent, and can lead to confusion, delirium, hallucinations, tremoring, balance problems, swallowing difficulties, reduced alertness, slurred speech, weakness. So we always bring that up very, very, very slowly. We don't ever run a hypertonic solution as like a bolus. You're going to be wanting to do very regular neural checks and be watching for signs of any change in your patient's mental status. So that really kind of is that last bullet point. The severe neurological symptoms can occur due to shifts of water from the brain's intracellular to extracellular spaces. That could also happen in reverse if you're giving a hypertonic solution. Remember that the fluid wants to follow where the party is, and you could actually cause, if you're not watching very closely, we could cause dehydration of the brain cells, and that would lead to some very detrimental effects cognitively as well. Potassium is the other major electrolyte that's involved in the sodium-potassium channel pump, and it is the main player in the maintenance of cardiac rhythm. It controls skeletal and smooth muscle contractions more than any other electrolyte does. It's primarily replaced by diet. It's excreted through urine, but also in the feces. Too low or too high could induce cardiac arrest for different reasons. So when we're thinking of potassium, I want you to think in your mind, I want you to correlate potassium with the word pump, because it pumps the muscles, right? If we have too much potassium in the body, then it's pumping too much to the extreme that I want you to picture like your fist contracted into, or your hand into a fist. If you've got too much potassium, it stays a fist. You can't open up your hand. It's just one steady long contraction, and that would lead to cardiac arrest very, very quickly, to VFib and cardiac arrest. The opposite, if you don't have enough potassium, you've got a very flaccid hand that is struggling with that contraction. It's weak. It's having a hard time forming that fist, and so you don't have a good contraction there either. You can actually see this through ECG monitoring, through EKG strips. When we see high potassium, we've got to think high pump, and if you know what a T wave is yet, I don't know if you've covered this yet in 340 yet, but your T waves will be peaked. They'll be very, very tall. If you have low potassium, then that T wave is flat. You might even see the presence of a U wave, which, for the record, everybody has a U wave. It's just that we don't usually see that on monitoring because it happens simultaneously as we see the depolarization and the contraction between the atrial and the ventricles. That U wave is hidden under the PR wave because they happen at the same time. But if you've got a patient that's hypokalemic, often we can see that U wave, which is an extra little bump between the T wave and the PR interval. There are some administration guidelines that you need to be aware of with potassium. We prefer to give it orally if we can. Oral supplementation is best if the patient can tolerate that. It can cause some GI distress. It's best if they can take it with some food. Sometimes, I want you to be aware, I don't know if any of you have given potassium orally yet, but some of the preparations, they're big. It's a really big pill, and so be really mindful if you've got a patient that maybe has some dysphagia. Can they swallow big pills? Do you need to split that up? They snap in half very, very easily. If we're running it through an IV, it needs to run slowly, and it always is going to be mixed with solution. You can find potassium added, like NS plus 20, NS plus 40 is very, very common, where the patient needs a little bit of supplementation for whatever reason. Maybe they're getting a lot of Lasix and the normal isn't quite enough in the hospital setting. And so we'll give that over, throughout the course of their stay, a little bit of extra potassium there. But maybe their lab levels are lower than that and they need more. Maybe they need, it's typically given in 20s and 40s in a bag. If you have a bag of 20, it's usually mixed in a bag of NS, 200 mils, and you'll give it over 2 hours. Is pretty standard. If you've got 40 milli equivalents, you'll give it in 400 mils over 4 hours. Those come pre-mixed to you from the pharmacy generally. That's not something you'll mix on your own, and there's a very important reason for that. Potassium is a very, very, very high alert drug. If you give too much too fast, it will cause that constant state of contraction. It will lead to cardiac arrest and sudden death. So that being said, I want you to know, go to that last bullet point there. Let's jump ahead. We never, never, ever push potassium through the IV. Now, that doesn't mean we don't give potassium through an IV, because we do all the time, a lot. That means we don't push it. That means in a syringe, straight potassium in a syringe, push through that hub. We never, never, never do that. It will always be mixed, diluted, in solution, run slowly. The general rule is 10 milliequivalents an hour. With an order, you can run it at 20 milliequivalents an hour if your patient's on telemetry. We never run it faster than that. Never, never, never. And if you're going to run it at 20, you better have a doctor's order to back that up. Okay? I would say the only time that you would ever push through the IV is if you work in a prison where they do death row. If you're part of the death row squad, you might have the opportunity to push potassium because that's what they use for that. Also keep in mind that when you're running it through an IV that it can cause burning, stinging. It's pretty common. It's a common complaint. It's an irritant to the vein. And so really the fix for that is to run it more slowly. Or if you can piggyback it into another solution of NS so it's even more dilute, that will help quite a bit. A lot of facilities will put a little lidocaine in the mix to make it a little bit more comfortable. It's important for you to educate your patient if they're complaining that that's totally normal. But on the other hand, you need to be assessing that at least hourly to make sure that it's not infiltrated, because it can be necrotic. Okay, so assess that IV site very, very regularly for inflammation and swelling and heat, warmth, stuff like that, redness. any weeping where you can see there's leakage. If that is the case, you need to stop that drip and move the IV. But if everything looks good at the IV site, then just slow it on down. Especially don't stop that pump if the patient has critical low values, unless there's a problem with the IV, and then you need to get that changed over. Too high can cause hyperexcitability that could lead to paralysis of the contraction. Too low can prevent the contraction. So when we see that, usually when it's too low, I'll see like PVCs, maybe a little VTAC, because VTAC is a run of PVCs. That's not generally an emergent situation, but when there's too much, we might see VFib, and that is for sure an emergent situation. So just keep in mind that we never run potassium without using an IV pump. There are 4 rules I want you to remember with potassium, and they all revolve around protecting the heart. So if you're running it IV, gold standard is to put that patient on tele. If you're running it up to the 20 milliequivalents an hour, they need to be on telemetry. Again, we never push it straight through the IV. Number 3 would be that 10 to 20 milliequivalents an hour parameter. And number 4 is always use an IV pump. The other thing that I want you to remember about potassium, and this will come up, I don't think it will come up on this test, but it for sure will come up on your second exam for most of you, because you're going to be studying cardiac medications and diuretics. And potassium interacts with a lot of medications. Digoxin is one of the big ones. Hypokalemia can lead to digoxin toxicity. Digoxin toxicity can lead to hyperkalemia, and we'll talk about that later on. But just know that there are some that you need to be aware of potassium's relationship with different medications. If you're giving a diuretic, potassium most likely is following the fluid, and you're going to need to replace it. Unless you're giving a potassium sparing, if you've studied spironolactone, then you're going to want to be watching your patient to make sure that they aren't taking in too much potassium. They're going to be on a potassium restricted diet, possibly. A couple other medications that can spare the potassium would be like lisinopril or losartan. Your ACE inhibitors, your ARBs can be affected by potassium. In that same line, you're going to want to do some patient teaching so that your patient understands where potassium is found, right? I think we think of bananas all the time, but it's also very high in cantaloupe and prunes, orange juice, dried fruit, nuts, molasses, avocados, lima beans, bran cereal. So again, just remember that if they're taking in too much, we've got that constant contraction and could lead to sudden death. And if they aren't taking in enough, then we're going to see a slowed contraction rate. Either one could lead to an adverse cardiac event. Magnesium is one of the main cations that's present in the intracellular fluid. Where potassium is, it has a very close relationship with potassium. So generally, if a patient is low on potassium, they'll be low on magnesium as well. And a lot of physicians will order a magnesium supplement at the same time that you're giving potassium. It does play a role in cardiac function and water regulation. Its cardiac function role is not in the same way that potassium works. Potassium, remember, helps that contraction happen. Magnesium has the opposite effect. Magnesium, just think of it as the relaxer. It's kind of chill and relaxed, and if you have too much magnesium in your system, then you won't get that contraction that you need. It relaxes cardiac muscle, it relaxes smooth muscle, and we'll talk about how it's used in that role in just a minute. It also acts as a water regulator, so think of milk of magnesia when you're constipated or whatever. as that water regulator, it actually brings the fluid into the colon and helps flush things out. It does help move sodium and potassium across the cell membrane. It is commonly given to pregnant women with preeclampsia or with pregnancy-induced hypertension. So I just talked about how it relaxes that cardiac muscle and the smooth muscle. So if you've got a woman that's preeclamptic with that high blood pressure, to relax that a little bit would dilate and relax that a little bit. It also is given for women that go into like preterm labor to help stop the uterine contractions. It also can be used as an anti-seizure medication, especially if the seizure is induced by a magnesium deficient state. So when we're giving magnesium, especially like say to a pregnant mom through the IV, you would want to keep calcium gluconate close. That is the antidote if magnesium toxicity occurs. It is a lot more common to experience magnesium toxicity than it would to have adverse effects from not having enough magnesium. I'm not going to say that it's common to have magnesium toxicity, but just know that that risk is there, especially when you're administering the IV form. Oral supplementation, not so much. It could be hard on the kidneys and could lead to toxicity if you've got some degrees of renal failure, because it just doesn't clear. But other than that, you want to keep calcium gluconate close if you're giving IV form. And the reason that's so important is because it is a muscle relaxant. You could have a patient go into respiratory failure or respiratory distress because their respiration's slow so much. It can lead to sedation and confusion because of that lack of oxygen. Other effects of that would be you would want to check their deep tendon reflexes, because if they've got too much magnesium, that reflex won't be present. Just like think of having too much calcium would do the same thing. Other assessment findings would be flushing of the skin, intense thirst, and a neuromuscular blockade. And then we've got calcium. Calcium is a salt that's primarily used in the treatment or prevention of calcium depletion in patients whose dietary measures are inadequate. It's found in the body in both the intra and extracellular spaces, and we find it, of course, in the bone. It plays a critical role in the transmission of nerve impulses. It does affect cardiac muscle. It's needed for blood clotting and teeth and bone formation. It is regulated by the parathyroid hormone, by calcitonin, and it has a relationship with vitamin D. We'll talk about vitamin D in a few more slides, but calcium needs vitamin D to be absorbed by the body. Hypercalcemia results in a muscle that cannot contract because of the constant state of contraction. So it's very much the same principle with potassium. If you've got too much calcium, that contraction cannot release, which would lead to a cardiac arrhythmia. It also could lead to constipation because it stops that muscle through the GI tract from contracting. That peristalsis effect would slow, which could lead to an ileus, a paralytic ileus. Hypocalcemia, not having enough, could lead to bone loss, to VTAC, numbness and tingling of the face, mouth, hands, and feet, which we call that paresthesia. And it could also result in muscle spasms in those areas. So you can check for a calcium for hypercalcemia, much the same that you would check for hypermagnesium, but for different reasons. But those deep tendon reflexes would not be present because the muscle would stay in a contracted state. Parenteral nutrition, supplementation, which remember parenteral means that it's going into the vascular space. So this is IV administration is the preferred method for patients who can't tolerate or maintain adequate central or enteral or oral intake. So this parenteral nutrition, we call it TPN, which is total parenteral nutrition, provides all the vitamins, minerals, amino acids, dextrose, and lipids that the patient needs to receive total nutrition. When we give it this way through the vein, it bypasses the entire gastrointestinal system, which it eliminates any need for absorption, metabolism, or excretion. We always want to give a patient enteral feedings if they can tolerate that. It's better if it does go through the gut, but there are circumstances where we don't want to do that, where the gut's not functioning, or they've had surgery through there, or something where they're at higher risk of that kind of feeding. And then we'll go with this IV form. It's usually given through a central line, but it can be given through a peripheral vein. It's not nearly as common in my experience. If it's ordered that way, we'll call it PPN, which is peripheral total parenteral nutrition. And that would only be used if it were going to be really short term, and there are some criteria that has to be met for a patient to receive it through a peripheral vein. The dextrose amount has to be lower, less than 10%, and amino acids have to be less than 3%, and they have to require less than 2,000 calories a day this way. And also their veins have to be able to tolerate a heavy fluid load. When we put it through a central line, those can be more concentrated amounts. The dextrose can be higher, the amino acids can be higher. If the patient has any fluid restrictions, they can pack more of the nutrition into a smaller amount of fluid as it goes through that bigger vein. If you happen to have a patient that's having it through a peripheral vein, just be really, really mindful of monitoring that IV site very, very frequently, at least hourly, looking for any vein irritation or inflammation, because if that phlebitis happens and it's severe enough and it's not treated quickly and appropriately, it could actually lead to the loss of a limb. That's not very common, but it can happen. Another potential adverse effect would be fluid overload for a patient because they're getting this nutrition in a higher amount of fluid. Central, when we use a central line, you would want to be really mindful of watching for signs of infection. That's really the biggest side effect to giving TPN through a central line. Really giving, anytime you access a central line, there's a risk of infection there. So you're going to want to maintain aseptic technique at all times. You're going to want to be flushing. You need to be changing the tubing according to your facility's policy. A bag of TPN should not hang for more than 24 hours. So if the patient hasn't finished it in that time period, it needs to be thrown out. You could have some TPN that's actually mixed with lipids, and it needs to it can't hang for 24 hours if it has lipids in it. Most places that I work, we hang them separately. The lipids run for over like 4 to 8 hours, and the TPN runs continuously, but every 24 hours we hang a new bag, whether they have finished it or not. So just be mindful of what you are hanging, what your hospital's policy is, and follow that very, very closely. I think that's really all you need to know about TPN for this is just to be mindful. I will mention that if you've got a patient that's on TPN, you should be really monitoring labs as well. You should be looking for signs of fluid overload. You should be looking for kidney function, for muscle wasting or breakdown. We want to be looking, signs of any nutrition deficit. And for sure, since this is replacing other calories, they add a lot of dextrose to that solution. And so you're probably going to have blood sugar checks ordered, even if this patient is not diabetic. Your patient might question why they're getting, why you're checking their blood sugar, and they might be concerned. And so just, know what you're teaching and why. It also needs to run through an infusion pump. We don't just hang this bag to gravity. It needs to run at a controlled pace, and so make sure you're using an infusion pump that you can program. And again, here's just some nursing considerations for you to remember and think about anytime that you're administering any kind of parenteral nutrition. Make sure you're looking for nutritional assessment findings, and pay attention to their dietary history, any allergies. Make sure things aren't added to that they might have an allergy to. Monitoring their weight daily is very important when we're assessing nutritional status. I talked about the glucose values already. The BUN would be your kidney function, CBC, fluid overload, and then the phlebitis, because that can cause that vein irritation or the inflammation. And like I said, a central vein really is the gold standard. I think most hospitals, that is their policy. And so I would anticipate an order for a central line if you're in a hospital setting, or even for home. Patients can be discharged home and have home health come in and set up TPN for them as well. And so usually if that happens, they do go home with a central line, because it's just more risky to send them out with a peripheral vein and not have somebody continually monitoring that for them. So I would just say anticipate a central line placement. If you see an order and you don't have a central line, question that. Okay, so we're going to lastly talk about vitamin supplementation. So vitamins are organic compounds that are essential in small quantities for normal physiologic and metabolic functioning of the body. Some of these vitamins our body produces on its own. Some of them have to be taken in orally. We have to ingest it in foods or in supplements that we take. And they are either water soluble or fat soluble. The water soluble vitamins can be dissolved in water, and they are easily excreted in urine. And it should be noted, we'll talk about it, but water soluble vitamins are not stored in the body. The body gets rid of what it doesn't use, so that has to be replaced often. Fat soluble vitamins can be dissolved in fat, and they tend to be stored in the liver and the fatty tissues. And so with that being said, it's important to know that too much could lead to toxicity. There's some patient education there. You might have a patient say, why does it matter that I take too much vitamin A? I mean, isn't that good for me to take too much? And the answer is no, it could lead to toxic levels. And so I want you, as you go through these slides, to make a mental note of which ones are fat soluble and which ones are water soluble. So the fat soluble vitamins are vitamin A, D, E, and K. They are present in both animal and plant foods. They're stored primarily in the liver. They go through a very slow metabolic process as they're broken down. They're excreted by the feces. And generally, daily ingestion is not necessary because the body does store it in the liver and the fatty tissues. And if we are taking too much of some of these vitamins, we could reach toxic levels. Let me circle that for you. I guarantee somebody's going to have this on a test. You could reach toxic levels if excessive amounts are consumed. So let's talk about vitamin A first. Vitamin A is derived from animal fats, such as those that are found in dairy, eggs, meat, liver, fish liver oils, also plant-based in carotene, such as yellow and green veggies and yellow fruits. Vitamin A is essential for normal and night vision. It is essential for normal cell growth. A normal diet usually provides sufficient amounts, so most people do not need to take vitamin A supplements. And again, this is one that is fat soluble. Vitamin D. Vitamin D is known as the sunshine vitamin, and there's a reason for that, which we'll talk about. It's responsible for proper utilization of calcium and phosphorus in the body. It is found in both dietary sources and is produced by the skin by the ultraviolet irradiation of the sun. So this is why it's called the sunshine vitamin. You can synthesize vitamin D by going outside and getting some sunlight. It's found in fish oils, salmon, sardines, herring, fortified milk, bread, cereals, animal livers, tuna fish, eggs, and butter. It is necessary for normal calcification of bone. So I want you to think, when you're thinking about bone, circle that, then maybe you're thinking about calcium, right? Can't see that red on red. I want you to link vitamin D and calcium together in your mind. They have a very inverse relationship. If it's easy for you to remember that vitamin D is usually added to milk, and think, well, milk provides a lot of calcium, right? Maybe that will help that in your mind. That vitamin D helps the body use calcium. It helps coordinate the parathyroid hormone and calcitonin to regulate the serum calcium levels. Okay. Rickets is the main problem caused by a vitamin C deficiency, which manifests as soft, pliable bones, muscle pain, chest deformities, enlarged skull. There's some other things as well. And then it is one that is fat soluble. Again, remember the vitamin D and calcium work hand in hand together. The vitamin D is necessary for calcium absorption. Okay. Okay, so vitamin E is has powerful antioxidative properties, and it's an essential component of the diet. It's believed to protect polyunsaturated fatty acids, which is a component of the cellular membrane formation. It comes from both plant and animal sources, and it is another one that is fat soluble. Okay, so vitamin K is a fat-soluble vitamin, but the body doesn't store large amounts of vitamin K. It is synthesized by the intestinal flora, which provides an endogenous supply, so that does mean that the body can produce that on its own. It's essential for the synthesis of blood coagulation factors, which takes place in the liver. It's an antidote for warfarin or coumadin if there are high levels. Some good patient education for if you've got a patient that's taking Coumadin is if they're in therapeutic range, to watch their vitamin K, not to suddenly start eating a lot more or start eating a lot less than they were, but just to maintain their regular status quo. We find vitamin K in, I think it's most known to be found in like green leafy vegetables, but it's also found in other things like cantaloupe is high in vitamin K, and some other foods as well. But just let your patient know they'll be going in for lab work every 3 weeks or so for the time that they're taking Coumadin to make sure that they stay in a therapeutic range, and their doctor will adjust their dose based on whatever that PT-INR is. And so they don't say you had a patient that was suddenly they're in therapeutic range and suddenly they start eating a lot foods that are high in vitamin K. What would happen? Their blood would be clotting, right? The Coumadin would not be effective if they suddenly started eating more vitamin K, and they'd be a much higher risk of stroke. As opposed to if they just suddenly stop eating foods in vitamin K where they were taking, eating enough before and they're still taking Coumadin, then we're going to see where their blood is way too thin. It's important to know that deficiency states can be found in newborns because of a malabsorption due to inadequate amounts of bile at birth. So basically, newborns are born with a sterile gut. They don't have the normal flora in there that's needed to produce or to synthesize vitamin K. The liver can't do that yet. It hasn't produced the bile. And so these babies are at really high risk for bleeding. And so here in the United States, it's pretty standard practice to give a vitamin K injection intramuscularly within a few hours after birth, usually before they go back to the nursery. They usually do that right in the mama's room. And it's important for you to know so that you can provide adequate patient education, because we're seeing trends where kind of with the anti-vaccination movement that's been happening, is there's a misconception that this vitamin K injection is a vaccination, and it is not. It is a vitamin supplementation that's necessary to help these little kiddos produce this vitamin K so that they can produce their clotting factors. Anyway, the trend that we're seeing is where a lot of parents are refusing the vitamin K for their infants, and as a result, we're seeing higher incidences of infant death related to it. These newborns have bleeding problems, and so just keep that in mind, that you need to be aware why we give vitamin K to newborns, how it's given. It's not given orally. It's not drops in the eyes. It's an injection that's intramuscular, and it's given within a few hours after birth. Okay, so water-soluble vitamins aren't stored in the body in any appreciable amount, and so that means that the body excretes what it doesn't need, which would mean that toxic reactions are very rare. It would be really, really hard to have a toxic level of a water-soluble vitamin because it is excreted. The body gets rid of what it's not using. That being said, these vitamins need to be taken regularly through dietary means, adequately and regularly, because there is no storage there. And the main players here would be your B vitamins and vitamin C. All right, you guys, good old vitamin C. It is water soluble, meaning that if you take tons of it, you just are making really expensive urine, right? You'll excrete it in your urine. You cannot overdose on vitamin C. A deficiency can result in scurvy. It aids in wound healing, collagen synthesis, and the maintenance of connective tissue. I've actually heard of recent studies where they're using vitamin C therapy in the treatment of sepsis, and it's proving to be effective. So I think that's pretty amazing that a vitamin like this could make such a difference in the fighting of infections. It's also important for the maintenance of bone, teeth, and capillaries. It helps folic acid convert to its active form. We'll talk about folic acid on the next slide. It does enhance the absorption of iron. I would file that away somewhere in your mind, that enhances the absorption of iron. It shouldn't be taken at the same time as iron, because iron will bind to things and it will make it not be as effective. But having enough vitamin C in your body when you're taking iron supplements will help open the gate for the iron to be absorbed. It is required for the synthesis of lipids, proteins, and steroids, and it aids in the resistance of infection. And again, I think this is why it's used so much in cold medications, preventatively, or some people swear that if they take large amounts of it, their cold either gets stopped before it really starts or it ends sooner. And like I said, it's being used in the treatment of sepsis in some facilities now. All right, you guys, we are almost done. Folic acid. It is a water-soluble B complex vitamin. The human body requires oral intake of folic acid. It does not synthesize this on its own. We find it in dried beans, peas, oranges, and green vegetables. Evidence does support its use in the prevention of neural tube defects, such as spina bifida. Because of this, there are prenatal recommendations that that women, before they even get pregnant, like a month, at least a month before, start taking a folic acid supplement. I would say all prenatal vitamins contain folic acid, and it's recommended that they continue that throughout the first trimester at least, while that the neural tube is developing there. So tuck that away somewhere. I guarantee some of you will have on this test a question about folic acid in fetal development, and it's going to be related to this neural